Everyone to this video. My name is Ryan and I'm a hospital pharmacist. Today we're talking about VTE prophylaxis and specifically we're talking about the general medical patient. So we're not non-surgical patients. So just an outline for this video. We'll first talk about some basic principles of thrombosis, and then we'll talk about how we approached thromboprophylaxis. Let me just get rid of this. So before we get into the discussion, we will just talk about some basic pathophysiology. I'm sure you've all heard of the Virchow's triad, or the Virchow's triad, if you like. So, and the components include hemodynamic changes, so stasis and turbulence, and we've got endothelial damage, and hypercoagulable state, so coagulability, excuse my spelling. So these are the three broad factors that impact the risk of thrombosis. So just keep this in mind while we go through this discussion. So the first thing that we need to think about is who is the patient that's at risk of thrombosis. So in general terms, as age increases, the risk of VTE and blood clots increase, and same goes along with comorbidities. But to list the common risk factors, there are things like malignancy. Why? Because malignancy leads to the state of hypercoagulability. There is immobility, and that's the stasis part of this triad. There is chronic heart failure, congestive heart failure. So this is associated with both stasis and also endothelial damage if there's any atherosclerosis. Other common risk factors include sepsis and respiratory failure. Okay. So these are some of the common risk factors. There are others. So if someone has a history of blood clots, they're at increased risk. Things like inflammatory bowel disease. When you see inflammation, you can think a state of hypercoagulability. And pregnancy is, of course, the other big one. So we've talked about this. Now we'll talk about how we approach prophylaxis, VTE prophylaxis. The first thing that we need to do is we need to do a risk stratification. So stratify risk, VTE risk. So this is usually done empirically based on the risk factors that we've already talked about. But there are some tools that we can use to help us do this. So there's things like the Padua score, which you can use on your mobile phone application, things like MedCalc. And there are some other prediction scores such as the Geneva score and Improve score you can use to predict the risk of a patient getting VTE in the inpatient setting. So what this tells you is if the patient is low risk or if a patient is high risk. So typically, if anyone has been deemed to be low risk, there is less than 1% risk of developing VTE. With the moderate to high risk patients, and there are variable estimates, but up to the risk is up to 10%. The good thing is that with the VTE prophylaxis, this risk is reduced down to 2%. Now, okay, so we've done our risk stratification. We've identified a patient who might need VTE prophylaxis. What's next? So the next thing to do is to assess the risk of bleeding. Let me just change my color. So, bleeding risk. So this is done using history and examination. So who would be at risk of bleeding? The obvious examples are anyone with a gastrointestinal bleed. So an active bleeding, anticoagulation is contraindicated here. Any hemorrhages, so intracranial hemorrhage, for example. I would add to this list anyone with severe thrombocytopenia, any sort of platelet disorders, moderate to severe coagulopathies. And yeah, so these are the major bleeding risk in a patient, and the bleeding risk needs to be assessed before someone is commenced on anticoagulation. So we've done this. Now we just go to our decision-making tree or diagram. Okay. So if I put bleeding risk here, risk of bleed, and a VTE on the side. So I'll just change my color to a different color. Sorry. So if anyone is deemed to be low risk for VTE, they typically don't need any pharmacoprophylaxis. So this is a young and healthy patient. So an example would be a young patient who had a syncope for an episode of hypoglycemia, was admitted to Gen Med for observation for 12 hours, for example. So the best thing to do with these patients is early ambulation, sorry. So early ambulation plus minus with or without mechanical prophylaxis. Okay, we'll come back to this one. The next cohort of patient is those with high risk of bleed and also moderate to high risk of developing VTEs as well. So someone, for example, who's got an active GI bleed. So in these patients, the other option is to use mechanical prophylaxis. So excuse me, I'll just get rid of this. So we can use things like intermittent pneumatic compressions, or there's the graduated compression stockings and things of that nature. So these are basically venous squeezes. So they enhance the blood flow in the deep veins in the legs. So they do two things. So if I draw the workouts, try it again, they reduce stasis by means of enhancing blood flow in the deep veins, but they also reduce coagulability. There are some studies that show that these particularly the intermittent pneumatic compressions, they reduce coagulability by increasing fibrinolysis, so they also reduce coagulability. Yeah, so these mechanical modalities are very good for this cohort of patients. The other thing to keep in mind is that if the bleeding, to reassess the bleeding risk for this group of patients, if the bleeding has been reversed or if the patient is now was at low risk of bleeding, then there may be consideration to change them to pharmacoprophylaxis. What about the IPCs or graduate stockings for these cohort of patients for your low VTE risk of patients? So we could use them, but they're generally not recommended because what they do is they tend to confuse patients and they tend to cause immobility, and there's also the risk of skin tears and ulcers and things like that. So we generally avoid using these for low risk VTE patients. And same goes with patients with high VTE risk but low bleeding risk. So in these patients, pharmacoprophylaxis is recommended. Prophylaxis. Is that pharmacoprophylaxis? Okay. And when we use pharmacoprophylaxis, that's plenty, and we don't need to use mechanical prophylaxis for these patients, just for basically the same reasons. So what are some medications or what are some agents that we can use in patients that are at high risk of VTE and low bleeding risk? So the low molecular weight heparins are the mainstay for VTE prophylaxis. So we use enoxaparin or clexane, and we dose this at 40 milligrams subcut daily. Okay, so I'll just get rid of this subcut. I'll just put SC. My friends always get angry when I use it sub-Q, so I'll just put SC there. Subcutaneously daily. If anyone has a creatinine clearance of less than 30 mils per minute, we dose them at 20 milligrams subcut daily. But if anyone has severe renal impairment, we tend to use heparin. And this is dosed at 5,000 units BD or TDS. Heparin is also used in countries where the things like clexane are very expensive to use still. So they're cost effective, and also you don't need to dose adjust in renal impairment. The dosing is a bit controversial between BD and TDS. The TDS dosing might offer some benefit over the BD in terms of reducing the VTE risk, but this is not a significant reduction in risk, and the risk of bleeding does go up with the TDS dosing. So a lot of the guidelines tend more towards the BD dosing. But all the doses have to be individualized for every patient. So that's that. The other thing that I wanted to mention is that these are low doses of blood thinners. So if anyone comes in who is on anticoagulation, for example, if a patient comes in with apixaban for atrial fibrillation, we don't need to change their regimen. So we continue them on apixaban 5 milligram twice a day for the rest of the inpatient stay, and we don't need to add clexane to an anticoagulant because that then increases the risk of bleeding. So So consideration is if anyone is on anticoagulant. So to continue this, don't need to put them on Clexane as well. The same goes with warfarin. If the patient has a good and stable INR of between 2 and 3, then we can continue them on the warfarin, and we don't need to change the regimen. This is different for surgical patients, obviously, because if a patient is undergoing surgery, then we might need to withhold their warfarin and put them on Clexane and do a bridging sort of program. The last thing that I want to add is that these agents are contraindicated in anyone with a GI bleed or an active bleed, anyone basically who's at a high risk of bleed, and hemorrhages, so intracranial hemorrhage. They're also contraindicated in moderate to severe coagulopathies. So if the PTT is markedly increased, the other ones would be platelets less than 50 or less than 100 if there are other risk of bleeding, plus bleeding risk. And there are some other instances, for example, platelet disorders and things of that nature. And I will end this video here. Thank you for listening, and we'll see you in the next video.